in itself and a crisis in communication in terms of getting back online and getting the technical issues sorted out. So here we go. We're demonstrating relational leadership in crisis.
Action learning.
That's right. That's relational learning. So welcome and hello, everyone. Thank you for joining our very first roundtable for 2026. I'm Dr. Sydney Chandrasiri, Chief Executive of the Australian Institute of Health Executives. And Health Executive, AIHE, for those who may not be familiar with it, does three things: healthcare leadership development, thought leadership, and specialist advisory services. So today I'm thrilled to be finally half an hour late, joined by our exceptional panel of leaders from our Faculty Advisory Council. We have Lisa Collins from the UK, Dr. Tony Prado over in Brisbane, Paul Gretton Watson in Melbourne, and David Quigley in Melbourne. Have I got that right? Okay. I might let each of you introduce yourselves, but I guess I'll just do a bit of an introduction to the topic, and then we can get started since we've lost quite a bit of time. So today we're focusing on relational leadership, as I mentioned, crisis in communication particularly. And what we're going to explore is why communication breaks down in crisis, what relational leadership looks like in practice, how leaders can manage challenging and disruptive behaviours during periods of crisis, and how we can act to anticipate and prepare our teams to meet crisis in the future. So with that, I'm going to dive into the first question. Now, I'll do this open to anyone on the panel, so feel free to answer, and we'll cover those topics as we go along the session. So I'm going to get you to think about the last crisis that your organization faced. What was one communication mistake that your leaders made that we don't talk enough about? Who wants to start off? I will start with perhaps Lisa.
Yeah, I'm happy to jump in. And just to say, yeah, good evening and good afternoon to everyone, and good morning to anyone listening from the United Kingdom. And I think, Sydney, you've demonstrated this morning our communication in crisis and how you've kept a very calm head, getting us all online. I think for me, the interesting pattern that I've seen, and if I think back to the last crisis, well, I mean, they seem to be weekly at the moment, don't they, in healthcare? And I'm really interested in the pattern that I'm noticing around our nervous system, because I think regardless of the crisis, how people show up indicates what's going on in their nervous system. So, for example, if somebody's go-to response is always going to be fight or flight, that's going to show up in their communication skills. So I think actually managers and leaders having a better understanding of their go-to threat response is really helpful in any crisis situation. And if we know that about ourselves and we know that about each other, then I think that helps us to pull through. Because if I think about the question you've just asked, when I see things going wrong, it's because people have been hijacked into that threat response and they don't know how to control it and get out of it. And that's when the messiness happens.
Great, thank you for that, Lisa. Does anyone else want to share a key thing that they've observed in their particular roles? And I might go to you, Tony, from a clinical perspective. I'm sure you face clinical crises every day. Well, hopefully not every day. But over to you. What's one thing that you've seen leaders commonly mistake?
Firstly, nice to meet everyone. Secondly, I definitely wouldn't consider myself an expert, but I certainly would consider that I've got a lot of experience managing crises. I think the funny thing I notice is that the personality of someone in a leadership crisis is not that dissimilar to their personality in a medical crisis. But interestingly, they often approach it differently. And in fact, the techniques that work during an emergency medically work just as effectively during a leadership crisis. And I know, for example, that the most recent one I've had in the children's hospital has been around departmental roles and restructuring and people's rosters and everybody else having to change. And what has worked the best is the leadership showing good preemptive communication, defining whose roles were whose, like who was responsible for what particular role, providing lots of ongoing communication during the crisis. In other words, this is what's happening. It's when no one hears anything for a period of time, they start to panic. It's a bit like if you're resuscitating a patient and no one's seeing anything happening, unless it's clear as to what you're trying to achieve, people start to panic. And you can see that same personality come through. And then often the leaders have to make a clear and logical decision, communicate that, and then be clear with their process of achieving it. So it's got to be goal-orientated, not person-orientated. And that is about the thing that works best. And it's not that dissimilar to when we're involved in medical situations.
Great, thank you, Tony. Look, let's not do this as a question and answer thing. I'm very happy to open this up for general discussion as well. And we would love to have our audience participate as well. So I think, Hayley, you've got your hand up. Do you want to try talking, and we'll all hold our breath and cross our fingers that it works?
Yeah, Hayley's muted. Can Hayley unmute, or can you unmute her?
I can ask her to unmute, and maybe that will help. I think you've got to do that from your end, Hayley.
No,
Hello,
it's with
how
me.
you
Oh,
going?
yes, we can hear you. Yay.
Hi. That hand up was a bit of a hangover from previously, so my apologies. But
That's okay, but while you have the stage, would you
While I
like to
have the
contribute
stage.
something profound?
Oh, look, I was thinking about a crisis and what went well and what didn't go well from a leadership perspective with communication. And I think that the communication up and down was not clear. And I think that speaks to Tony's point around knowing whose roles and responsibilities are what, and being able to fall back into those regular, having those roles clearly defined, I think would have helped immensely with the particular crisis that I'm thinking of. Yeah.
Yeah, that's a really good point, because I think, it goes to that common phrase that under pressure, people don't actually rise to their training, they fall back onto their habits. So you can have all the protocols and procedures in the world, but at the end of the day, communication is what becomes very important when you're facing high pressure situations. David, and then Lewis.
Yeah, look, I can go back in time a little bit. Am I echoing?
No.
So, turn of the century, we had a few disasters. We had the Banda Aceh, we had 9/11, we had the Bali bombings, and we had the SARS-1. And the leaders in those situations all got together for a conference at Westmead. I think it was early 2000s. And the CEO of the hospital that everyone went to in 9/11, the survivors they got there, he said the one thing that really helped them manage the crisis was to communicate to the media. So that they set up a media tent, they put all the journalists and all the cameras in one place, and they gave them regular updates. They said, we'll give you an update in 2 hours, we'll be out in 2 hours, we'll be out in 2 hours. And so that communication got the public, knew what was going on, and probably a lot of the staff would be logging onto those updates. And he said that was the most useful thing that he did, and then they could get on with the job, and getting clinicians involved who just happened to be there for a conference were going to come and help. And I think, and Lewis has got his hand up, but I think that reminds of when we had the Legionella outbreak in Brisbane, and Lewis was our chief medical officer at the time. And the one thing he did was regular updates to the media, so he knew what was going on. And then the other thing, not only that, so the clear communication, but also planning. You've got to have you've got to have your crisis plans, and people need to know what their role is in that plan. They'll need to rehearse. And we saw the advantage of that in with the Darwin situation. I think Fiona Wood got an Australian of the Year because she was involved in planning the disaster operations if there was bombing or some kind of terrorist attack. We're going to need to mobilise everyone. So I think backing up what everyone else is, and you've got to keep a cool head. You've got to have humility, and also you've got to build those relationships before. You can't be a bastard and expect people to work with you well when the shit hits the fan. Excuse my language. Thanks.
Lewis?
Well, thanks everyone. And as the Chief Academic Officer, I don't thank you for the panel for joining us under duress and for all the people who have attended under duress. Aren't you fabulous? And I was just going to reflect, and I'd love Lisa to tell me if I've got this completely wrong, because I must say, since Lisa Collins joined AIHE, I've learned so much that it's actually the best learning I've had in months, in the months I've had the learning in years. I haven't learned so much in a short period of time. From a relational skill perspective in crisis, as David referred, there's been 3 major crises I've been the CMO. Legionella outbreak in Wesley, the floods of 2011 in Wesley, and a COVID coronavirus outbreak in early 2020. I make the following comments. I don't think you can lead effectively in crisis if you haven't established yourself as a leader with your team and the people you work with beforehand. I don't know how people would trust and believe in you in a crisis if they don't trust and know you in things are normal. If they don't know that you're with them in the normal situation, you understand who they are, what they do, and how they operate to be able to help them in crisis when they have to modify or to mitigate risk or mitigate problems on the run. That's the first. The second comment I make is that what I learned quickly, particularly through Legionella, it served me well in COVID. And even recently, when we had a murder of a colleague of mine at my clinical practice, when we were managing in crisis then as a little general practice, was to get in front of the social media and the media with your position early. They will adopt your positioning, take that like a statement that's official on your website, publicised early and consistently updated, takes the opportunity for people to create their own narrative away from them. If you present that this what's happening and you're upfront with it, they're less likely to create a narrative and hence less likely to create confusion. As an example for Legionella, we went and said, let's put all the results and put all the information on the website, be transparent early. People like the media can't create their own narrative because the information's there. They can't say you're hiding. So I think early management of the crisis is about managing the narrative, and I think you have to be honest and transparent. You're going to be caught out at some stage if you're not. So you tell what you know at the time, and you do upfront, and you provide that so it's a way that people can access it. It can't be just meetings where people can't all turn up. It can't just be by email. And the third comment I make is that you have to be present during the crisis. So I do know people who've managed crises online, including COVID, and you can't gain a lot of traction with your colleagues if you're not actually present and sharing the crisis with them. So sending memos from the sanitised halls of an executive office suite when something is happening on the ground is not going to be very practical. I mean, on the other hand, you can have a little bit over the top of every time there's a flood crisis in Queensland, our Premier will always be on the ground in a big heavy raincoat getting rained on to be present. But at the end of the day, it's what the people expect. So we saw that again today. If you're a Queenslander, you would have seen the Premier in Bundaberg. So they're my comments, but I come back to you, Lisa, saying what I said earlier. It's very hard to develop, in my view, the leadership skills and show yourself as a leader in a crisis if you haven't got something in the bank already.
Absolutely. And so 3 things for me, Lewis. Thank you so much for your lovely, really kind words. And I think you've nailed it, because if you think about the way that I see leadership, and I think we complicate leadership. And we use too many words to describe it. And actually, if we just really boil down to what we're talking about, and what I'm hearing you talk about, Lewis, is you establish trust. And we have to earn trust. And I see so many leaders and managers get put into their positions and they don't believe that they have to do the work of earning trust. Even saying it out loud when you're in a new role, I'm here and I will earn your trust. That's the work that we do day to day. And as Sydney said, when the crisis hits, you fall back onto patterns. So what I'm hearing, Lewis, is that you, in your day-to-day work, established the trust, established safety, belonging, connection. And that's the work that we do day in, day out. And then when the crisis hits, which will always hit at some stage within healthcare, then you fell back on those foundational skills and people were ready to follow you. And that's when I think actually, some of this leadership stuff and communication is really basic stuff. And I'm a fan of just going back to basics. So yeah, that's the patterns I'm noticing, Lewis, that you were talking about. And as you know, what I'm passionate about sharing.
So Lisa, what you're talking about, is that what relational leadership is? I mean, I think for our audience, it'll be good to first, as we move into that, define what it actually is, and then look at some of the examples you already provided, which is, well, what does relational leadership look like in practice when you have those high pressure situations?
Yeah, so I think the key to it is in the word relational. And this is a skill that we've all got the gift of being able to build healthy relationships. It's just that when we move into the leadership and management space, a lot of this leadership language just takes over and we forget the basic skills that we've all got as humans. We all have it in our gift to turn up and make each other feel safe. We all have it in our gift to turn up and make each other build trust and connection and belonging. We don't have to go on a fancy course or a master's degree to do that. We've all got those human skills. So when I think about relational leadership, it is about how can you, as a manager, as a leader, build the trust, build the safety, build the connection, build the belonging. They're the building blocks, because we talk a lot about psychological safety and lots of people don't know what that actually means in practice. The research says only 17% of people know how to implement it, from Amy Edmondson. So if we go back to the basics, that's what makes up relational leadership. So when I've worked for a leader who's demonstrated those skills, I have felt safe. I have trusted them. If the crisis hits, I will follow them. I know I can approach them. I can give safe feedback. So often in many organizations, especially healthcare, when we give feedback, we're berated for it. We're dehumanized, we're downplayed, all those things. Ask any whistleblower or anybody who's spoken up, and they'll tell you exactly what that feels like. It's very dehumanizing. So somebody who demonstrates those relational leadership skills has the courage to be able to be present and hold a space for very gritty, difficult conversation without taking it personally. And again, I think these are very grown up, very mature skills that we need to bring into the workplace. And it's the day-to-day work that when the crisis hits, we can fall back on that training. And that's the work of leadership. That's the work of management. And so often people learn on the job.
Yes, and it's almost around balancing that decisive action with the calmness and allowing trust and open communication within a team. Paul, what are your thoughts?
Yeah, thanks, Sydney, and hi, everybody. Look, my lens is slightly different in that I've got a clinical background, but I've been doing research for a number of years and just finished and submitted a doctorate looking specifically at respectful communication and more pointedly bullying in the surgical context. And so I interviewed 31 leaders across Australia and New Zealand, really digging into what was driving the sort of cultural and relational success and failure. And one of the distinctions that I just wanted to add to what everyone else has already shared is that the crisis type is important as well. So one of the things that was spoken about quite consistently was that if there was a genuine clinical crisis occurring in a surgical context, people looked to the senior surgeon, all my interviews were senior surgeons, to take charge. And so they could get incredibly directive. They could also raise their voice. Not that one, this one. No, quick, fast, and move, much more directive and intense type of communication that in other contexts, other types of crises wouldn't have been acceptable. or would have been more problematic. What they often said was then after the matter had been dealt with and the person was stable again and things had settled down, often they would apologize to individuals or to even to the whole team about why they had to get so feisty and directive in that sort of intense moment. And almost without exception, they were forgiven for that. So I think the thing people expected them. There was no issue. There was no people kind of needing to lick their wounds or take days off work because they were overwhelmed. They looked for that style approach, and there was a permission set that was different than other types of crises. And I think the surgeons talked about that a lot, that being able to finesse and understand and attenuate the crisis type. So if there's a known relational crisis between, for example, two teams in a hospital, that's when you're at risk of team A becoming incredibly positional, suspicious, and quite sensitized to anything that might happen between the team members, and that's where you might have all sorts of problems arise, and that's where they expect a different type of leadership to perhaps the former that I was explaining earlier. And I just was a little surprised about how much that showed up as a differentiation of the type of crisis that was being managed and the rules and the permissions that sit around that. The last thing I would add is that further to what has been said, that the most successful teams and the places where it seemed to work the best was where they had proceduralized the sort of the early phases, the preparation, the planning. So simple things like surgical checklists, getting to know who the team are, giving people explicit permission. If they see something that they don't think's right, please speak up. Getting brand new team members to introduce themselves and say a little bit about themselves. It might seem a little bit ho-hum or a little bit, procedural and perhaps meaningless, but teams that contrast to the difference between working in major teaching hospitals where that occurred and in private hospitals perhaps, or other settings where it didn't occur, found that there was an insurance, there was a greater psychological safety when they did do that sort of foundational permission setting, normalizing work at the front end.
Yeah, it's interesting for me to hear you say that a lot of that emotional, setting the tone or the emotional tone of that crisis situation is really what the leader does, and to a large extent depends on emotional regulation, if you will, yes, as a leadership skill. That's really interesting. We do have a few hands up. I don't know who was first, so I apologize. I think maybe Tony, you may have been first, so I'll go to Tony and then Jack.
Yeah, hello again. I find both the comments from the other panelists very interesting, because there is clearly different perspectives from different people. So I'm just going to make 4 or 5 straightforward statements that I think are relevant and leave it to everyone else to think about. The first one is that going on from what's just been said, there is a difference between being a leader and being a dictator.
Mm.
That's the first thing I would say. The second thing I would say is that we're talking about relational leadership. So in other words, it's about established relationships and how that transforms into the crisis. And I think the leadership style will come through. If you're already a good leader, that leadership style will persist. If you are not perceived a good leader, that will persist. But I think the things that make a difference is that you do need to remember, even in a crisis, you can be compassionate and caring. And that means supporting those people who are struggling in the crisis. And if they're defensive, helping them break down those defenses so that it doesn't interfere with everyone else's communication. That might include education during the crisis, because you can do all this while you're maintaining a crisis. And then be very clear with logical communication and not make it personal. So, in other words, you look at outcomes, goal focuses. This is what we're trying to achieve, not who's achieving it. And the other things is, the leader to be successful has got to have integrity. So people need to believe that they're doing the right thing by everybody, And they also got to have earned their respect and give everyone else respect, as well as be known to be honest, so that when they do communicate, people believe them. And the only other thing I would say is, with all that, is you need to think rather than react.
So Tony, that sounds like a whole lot of good things, but difficult things even for a leader to do in an emotionally, quite chaotic situation. So how can leaders practically, I suppose, leverage relational leadership to both manage themselves and actually do those things that you said?
I think from my perspective, a lot of it comes from your already established relationship and patterns. So people need to have that trust prior to the crisis, because they're not going to develop trust when they are anxious and stressed. So that is about your overall leadership style, and people knowing that they can talk to you or approach you when they're not happy or they're not comfortable with something. And that's where I think it's important. That's where the planning, like when people say they're planning for a crisis, really what they're planning for is good leadership so that the crisis will be effectively managed. And I think it's almost impossible to establish those things as a new situation at the time of the crisis if it's not a pattern, because as people have said, you fall back to your habits. If it's your normal habit, you won't have trouble.
Yeah, you've touched on some really important points there. The need for psychosocial safety in your everyday operations or in your everyday team meetings, where people feel safe to speak up and safe to be speak up or speak out, even though they are maybe afraid or feel threatened in certain situations. And you also touched on the issue about what we practice. Like, we do a lot of simulation exercises in preparation for disasters and crises, but they're all very procedural or clinical in my experience. None of them is about how do we communicate, or how do we actually pass information and understanding amongst each other in that situation. So with that, I might ask David for your thoughts, and then we'll go to Lisa, and then after that, Jack, we'll go to you finally.
Yeah, look, the thing that I keep hearing is that you've got to build those relationships before the crisis. So you need that psychological safety, you need the trust, and not only need trust, you need trustworthiness. So your behavior, you have to behave, you have to do what you say you're going to do. But with that, building those relationships before the crisis, I want to go back to Paul, because Paul, you talked about the crisis and the management in the crisis, that people were happy with the surgical didactic. I think that, I'm not sure that's the right word, but very much an imperative leadership, which you do tend to get in that situation for the surgeon to take leadership in those surgical crises. Did you, in your research, did you look at the relationships that the people you were interviewing had with their staff, whether it's upstream or downstream, and in different specialties, how their relationships were before those crises? Was there anything of that
No, it's
relationship
a really good point. What I would add is that the criticality of emotional intelligence just became so strong. A lot of surgeons, of course, are brilliant technicians, and they know and they pride themselves on being so. And what they become often very reliant on is when they develop a really close working relationship. Often this happens in private hospital settings more so than public. When they have a really close working relationship with somebody, they rely on them to help them with some of the relational interpretation and some of the softening of the hard message, or the picking up upon something before, nipping it in the bud before it becomes, because they may be so technical and so focused, they miss a lot of cues. So some of the more highly self-aware surgeons that I spoke to, whether it be talking about up the line or down the line, tended to develop these close, trusting bonds often with other individuals that could complement their skills and abilities and their shortcomings, and together, or sometimes it was even a trio. It could have been, the chief theatre nurse. It could have been the anaesthetist. Could be very attuned. They worked out how they could complement each other, and I heard some spectacularly impressive stories from people who recognised that they didn't have to know and do it all.
Yeah, what I'm interested there is those relationships. So, for instance, in my experience, I've been in technical situations dealing with a patient, families in pieces, and you have these fantastic nurse managers will come in, take the family away,
Yeah.
and counsel them, and you can get on with your technical job, where your empathy isn't front and central. With those people who develop those relationships where they are complementary. Is this something they've consciously done, or do you think those relationships have just developed because those people have different skill sets? Or are they saying, hey, in this situation, can you handle the people and I'll handle the cutting? Or do you know if they just happen to evolve, or did they consciously plan those relationships and then
It's a really good question.
uh,
Look, sometimes I
yeah,
find that if they've got relatively high self-awareness, they seek out a foil, somebody to balance them out, and particularly, and often they're later. I'll generalize here. Later male career surgeons often recognize that they need a foil to do their best work, and that's work they know that they've come to recognize. They've usually had a ton of feedback from a lot of people through their careers in life, and sometimes they're sent. So don't forget also that some of these people get themselves into a heck of a mess. They're on the receiving end of a lot of complaints or sometimes even civil claims and all sorts of things, and they are actively developed to be much more just much more mindful of how are they going to not continue to keep making the same blunders over and over again. And
yes.
so it's some people have got the awareness to put their hand up, and others need to be sent. And actually, you need to put a wraparound strategy for them and with them so that they stop making the same sorts of errors.
Yeah, no, that sounds good.
I think what you're touching on there, Paul, is still the importance of relational leadership development or
Yeah.
training in that space of how to
Yeah.
communicate in a crisis. Now, I am going to use this opportunity to announce that we will be launching a new program and a workshop on relational leadership that will be hosted by our faculty advisor, Lisa Collins. It's her very own work that she runs in the UK. So please watch out for that. That's coming to Australia very, very soon. And with that, Lisa, do you want to perhaps touch on, again, that relational leadership concept and how you would use that to particularly, let's say, manage a disruptive or challenging individual in a stressful situation? Because in those situations, we often see people act out of fear, act out of feeling threatened or worried and stressed.
Brilliant. Thanks, Sydney. So I'm going to just bring something else in just before I touch on your question. And it's something I've been noticing more and more of is messy communication and allowing the space and permission for messy communication. Because when you think about it, and our conversation here today is about how can we create and control and give skills and training around relational leadership. But interestingly, there is a part of our communication that is naturally messy. And we have to give space for it, and we have to give permission. And I'm going to give you an example with this as well, because this is where I think if it's done really well, it builds trust to such a deep level that you might not have been able to get to that deep level without the permission beforehand. And so just to give you an example, before the pandemic, I was a commissioning director opening up a brand new critical care hospital. So we didn't even know the pandemic was coming when I went into that role. And having commissioned lots of capital developments before, my meetings with my team was always, look, this is going to get messy. Because even though we'll put all the best planning in place, and this applies to all of these situations, you can put all the best planning in place. And I do advocate for the building of trust, the building of safety. But this conversation is also part of it as well, is given the permission for the messiness, the permission for the stress, the amygdala hijack to come in, people not to be behaving their best. But how as a team can we allow that and we apologize quickly and know that when the job is done, we can go to the pub afterwards and have a drink and pat each other on the back. I think it comes from my Welsh roots and rugby players. When I've seen them on any rugby player or fan in the room, you'll see them on the field basically beating the crap out of each other and then go to the bar afterwards and buy each other a drink. So I think there's a little bit of that we can bring into communication and just allow the space for, guys, we know this is going to get messy. And I think, Paul, you touched upon this with some of your work. Whilst the surgeons might have been in that command and control and in that moment of urgency, people forgave them. And I think that's for a number of reasons, because the trust and the safety would have been there beforehand. But also, if you've got that relationship already built, you can have those messy conversations and people will forgive quickly afterwards. But I do think there is also a responsibility for the leader to be able to upfront say, look, this might get messy, but we're still a team and we're going to pull through. And if somebody has acted out of line or behaved badly, they will apologize. So I think there's something really beautiful about that messy side of communication that we don't often talk about or give space for. And then to your question, Sydney, about what an individual was it so just repeat your question again so I can be fresh.
So you spoke about after the event, the individual who misbehaves or does something disruptive can obviously be expected to apologize, and we move on from that. But how would you manage that in the situation itself?
So I think really interestingly, there is, I guess depending on the crisis and the situation. So if you've got a good relationship, we can be quite forgiving about that. But if you have somebody who deliberately behaves poorly, doesn't refuse or refuses to kind of accept that and apologize, lacks the self-awareness. So I think what I'm a real fan of is looking at humans through the lens of the threat response rather than the management language that we have. So what I do and what I advocate for is if someone's showing up and they're behaving poorly, are they coming from a threat response? Are they coming from that defensive fight response? If so, what's behind it? And quite often when I see people behaving badly in the workplace, and especially around harassment and bullying, there's usually fear that's driving that. And so as an individual, you can observe that. It doesn't excuse the behavior, doesn't allow it. I think there's something about having the courage to be able to challenge in that moment, or at least pull aside and say, look, the way that you said that didn't land well. It hasn't landed well with the team, it hasn't landed well with me. And quite often in the moment, people lack those kind of phrases to be able to loop back around, because most people, if anything happens and it happens in a really aggressive way, it'll trigger their own threat response and they might go into that fight or flight and not be able to kind of speak. So it depends on the individual in terms of what happens in the moment. But part of the training that I do is to teach people the skills, how to stay calm and regulated in the moment, to be able to be curious and ask questions. And I think that's the training, that's the skill that I think we can do more of.
Absolutely. And your comment about pulling that person aside and talking to them away from the team, I think that also highlights the other aspect of relational leadership, which is, not just protecting the team, but protecting the egos of the people. Even though they are in a threatened situation, they do still have to work together. So your role as a leader is to actually, make sure that that is in place as well.
Absolutely. Just very quickly on that, Sydney, as well, because if you, just for anyone listening, so if you do challenge in the moment, then you've got a high likelihood that's going to trigger someone's shame response and they're going to become even more defensive. Yeah. So I think it's really important to be able to just be compassionate and pull that person aside. Look, do you realize this is how this landed? This is how this came across. So straight away, you can adopt that and know that you're not going to trigger a huge shame response and get under the barrage of defensiveness.
Exactly. Jack, thank you for patiently waiting, Jack.
That's all good. Can you hear me okay? I was just going to say, I think one of the best things a new leader can do is, for transparency and gaining trust, is to make an established pathway for feedback and concerns to be raised, and make everybody aware of it. Anybody who comes in as a new hire, or when you come into a new team, making everybody aware of that pathway. And that's both a great thing for establishing trust, but also reducing the chance of a larger crisis happening, because people will know that they can come to you and you have an open door for them. And then also people who might be in the position to start a crisis or be a bully will know that people will come and talk to you about it. So it completely sort of shuts down a lot of chances for those situations to occur.
Absolutely, yes. Does anyone have any specific responses or reflections to that particular aspect? David?
Yeah, I agree, Jack. So my current role, we have monthly catch-ups with the person I report to, which is great. And with that, we're discussing today with my boss, well, you've got to give me feedback, I've got to give you feedback, and we're working out what methods we could use. And it's important when you're giving feedback to people. I think what you're saying is that there's a few things really important in a crisis to keep you cool. But if you don't practice keeping your cool when you're not in a crisis, that's even harder to do. So practice your coolness when you are cool, and just to be centered and practice responding rather than reacting. And with feedback, it's important to have structured feedback. So that there's one that I think some of us would have read that book, Radical Candor, and they talk about the situation behavior impact feedback loop, which is great. And there's also, I think, is a motivational interviewing when we talk to people about the most important thing, listening, reflecting, validating, and then getting that person to provide options. And both of those can be very good to reduce the tension in a one-on-one relationship. But you've got to be able to do that in a crisis to be able to do it quickly. And one way, I think, to break the loop, we want useful phrases and want to say, as Lisa said, you might point out, well, that didn't land well. It's not like you. It's not your normal behavior. Are you okay? What's driving that? And that can help that person say, oh, I'm all right, I'll chill. Just to break the loop, just to say that there's something that's bothering them and that's not their usual behavior. And it goes back to, I think, with Tony said earlier, what we're looking at is it's not the who, very important not to blame a person for causing a bad situation, but to concentrate on the what. What are we trying to do here? What's happening? What can we do about it?
Definitely. So just that, yeah, I think it really helps with investigating the actual cause of the situation to begin with, because it allows you to get people's sides of it, and they're far more likely to be transparent about it if it's not a sort of questioning or you coming to them. And then also, yeah, as Lisa said earlier, it's not fun being a whistleblower or being the person raising a concern, and it's probably not fun for the manager to receive that either. So having those structured pathways really lowers the tension and makes what's an awkward situation for both people a lot less awkward.
Yeah, absolutely. And it's important. I think you mentioned talking about the manager, the piece of person you're reporting to is they've quite often got other stresses and other factors that are pushing them in a particular way, which we can go back to that puppet leadership webinar we did a while back. So that's really good points, Jack.
Thank you both. Paul.
Yeah, just very quickly, all I wanted to add to this really useful conversation is that there is a subcategory of folk that many people that are on participating in this roundtable tonight will have in the backs of their minds that almost doesn't matter what you do, all the reasonable stuff doesn't work. And I think we haven't got time to really unpack all of that perhaps in this roundtable, but just be mindful that there are categories of really tricky folk out there. And often they are often very high value assets to the organization. They're often quite brilliant clinicians, but they often do have what you might want to call a high conflict type of personality type. They've got real form, history of being problematic, history of doing a lot of great stuff as well often, which makes it really difficult for the organization to know quite what to do with them. And my comment would be that the actual strategies and tactics that you use for really high conflict individuals, and obviously narcissistic profile type individuals come to mind, perhaps for some of you, you do need to do different things. You need a different bag of tricks than what you would use with otherwise very reasonable people. There are things you can do, but if you keep doing what you would do with a reasonable person, you can often find yourself really exhausted. So it's really just a footnote at this point in the conversation to say, just be mindful that you might need some specialist focused help with how do you deal with some of those very time consuming individuals that might be causing really deep upset in teams and in cultures.
I'm dying to know, Paul, what your tips and tricks are for managing those particular individuals. But I will go to Rihanna and maybe come back to you to elaborate a little bit more on that.
Sure, if there's time, sure.
No, you can go ahead. Mine's slightly separate.
Okay, Paul, just very quickly, if you can elaborate.
Yeah, so I think you've heard people almost touch on this, that this shame response that Lisa was talking about. So one of the things that you do is recognize that these individuals have a disproportionate response to negative feedback. They have this almost take your breath away type response to negative feedback, which has you become incredibly defensive, which then fuels this very rapidly. It can often go from, a civil conversation to something going a little bit wonky to from 0 to 100 in seconds. So if you know that you're dealing with somebody who has that potential or has a history of being that way, how do you talk to them in a way? And you just have to have a mantra going through your head the whole time. Empathy, attention, respect, empathy, attention, respect, empathy, attention, respect. So you are doing everything in your power to keep your your voice lowered, you're leaning in, you're being respectful, but you're also not putting up with poor behavior. So the other part of it is having other acronyms like, make sure you're very brief, be very informative, friendly and firm. Make sure you set limits, So there are some particular tactical things that you can do, but the main thing that you need to not be doing is sometimes just trying what you would use with a reasonable person and wondering why you keep ending up feeling so run over by these exchanges, or them becoming so disproportionately escalated and emotionally charged. And fundamentally, the bottom line of this, these individuals operate on an emotional plane, and that's where they get their bulk power or the maximum power, and you're working on a rational plane, and often there's a huge gulf between the two. So how do you recognize when somebody's trying to drag you to their emotional plane, which is where they do they're very comfortable in that really highly emotionally charged space, but you're not, and they know it, and that's where they can really dominate you. So it's about recognizing dynamically what's going on and managing your interaction very carefully, because otherwise you get drawn into their drama, and they will be far more practiced at managing that dynamic in the moment than you may be.
I think you've touched on one of the greatest challenges for leaders in terms of understanding those variations between individuals and adjusting your responses accordingly. So that's really important. And that's what I think makes a difference between an average leadership response versus a great leadership response. Thank you for that. David and Tony.
Yeah, just I want to go back to Paul, because that's very relevant to some issues I've had to handle recently. I'm just interested, have you got any recommended any reading or resources for that? What you described there was just priceless.
Other than Lisa's amazing book, I'm sure, but I would say in terms of this stuff that's
Paul, or published papers on this?
Yeah, I've got loads of stuff. So, but I think if you just have a look at maybe some of the work of Bill Eddy, it's very accessible. Bill, separate surname Eddy. And he's done a lot of work in this space in the US. And there are other, I'm happy to give to Sydney afterwards and share with the audience some other sort of resources, but they have some very good frameworks, some very practical kinds of tips for one, how do you recognize you're dealing with somebody who might fall into this category? What, are they doing that splitting, all good, all bad? Have they always got to have a target of blame? Do they lock on to a target of blame and just absolutely go after, really go after them? There are certain traits of these individuals that are very different to a reasonable person who might be under stress. So I'm just suggesting that we just need to be tuned in and on a bell-shaped curve. Thankfully, they're outliers, but they can consume the chief of surgery or the senior exec a disproportionate amount of their time, and often they've completely exhausted all of HR's tricks, and you need a very kind of focused and specialist approach.
Yeah, I think something they were saying not to get drawn into that emotion, and it reminds me that there's a kiddie behavioural book, a local psychiatrist here on the Sunshine Coast, right? And she says, "Don't get drawn in the jungle. Stay out of the jungle."
Exactly.
Great stuff.
Or feel free to type into the chat any of those resources for our attendees if you can. Tony.
I would just like to make the point that this discussion we're having as a pediatrician is identical to the discussion we have with parents who are looking after difficult 2 to 5 year olds. It is almost identical in that you need to teach the parent how to be very clear in their own head what they're trying to achieve and how not to react to the behaviours, but at the same time be highly affirming to the good stuff that they're getting from the kid. And and to give the child choices, but whichever choice they make is actually one of the outcomes you want anyway. and I think, and no offense to anybody who's listening, but honestly, that's what I'm hearing.
That's a very good analysis and summary from our pediatrician. I love that. And I think he's also called all healthcare leaders glorified parents, really, or glorified babysitters, rather. All right, Rihanna, you've got your hand up.
Yeah, so I just moving off the sort of disruptive clinician conversation back into the crisis conversation. I'm a public health physician separate to my clinical role, and so our bread and butter is around large-scale crisis communication at population levels for nationally significant infections and outbreaks, like Lewis was mentioning, also floods and fires and evacuations and all of those styles. So I guess that just for different members of the audience, I think there's a different relational model there where you're working with populations instead of individuals. And, often in those situations, it is an incident control structure, command and control structure. So you're more based on knowing your role within that structure rather than having this deep trusting relationship beforehand necessarily. And you need that sort of clarity of role and scope to be effective in those circumstances. But then there are those trusted relationships and networks built before that time, and there's a lot of work done in preparing people for those. So there's value in that. And then I think just to say the other resource that's really useful is actually understanding how your communication influences people and modifies behavior and how to match that to the level of risk. So, Peter Sandman would be the sort of model that you'd look at here, where he describes the public's perception of risk is a factor of how they perceive the hazard and whether they're outraged by it. And then you might need to actually move people into recognizing a risk through the way you communicate when they haven't really perceived the threat, or you might need to calm people down and knowing which quadrant of that hazard outrage kind of axis that people might be sitting in and what you want them to do is another sort of style of crisis communication I just wanted to flag in this conversation.
No, that's really important. That different context changes your approach almost, in its entirety. What would your response be to that, Lisa?
So I just want to pick up on the command and control bit, because I think that's really interesting. I've been doing some work with some special forces guys recently, and in healthcare, when we talk about command and control, we're not really understanding what that means. We're not actually practicing command and control in the way that command and control actually operates. It comes from the special forces. Within those special forces teams, there is absolutely high trust. It is built on high trust. It's built on clarity of role. There's hierarchy there, but within that hierarchy, there's clarity of role, and there is absolute high trust, high safety, and high love for each other, because these people have got each other's backs. They're in life or death situations. So it's really interesting when we talk about command and control, because I think in healthcare, we're not actually doing command and control as we actually think what it actually is. Because when we look at the root of it, it is built absolutely on high safety and high trust, even in those crisis situations. So I just wanted to add that, because I think it's important to just to bring in some of the roots of command and control and how we can use it better, because trust is absolutely the core of it.
How do you balance that, though? That's a question that I have. Practically, how do you balance that decisive command and control decision making, instruction or direction, and the empathy, the trust, the soft skills that we were just speaking about?
Well, I suppose in those kind of high risk situations, there is a goal to be achieved. And I think that's when the people come together as a team and everyone's going to achieve that goal. And that might not look like clear, calm communication. It might be messy, but within that, everyone's really clear on their roles and what needs to be done in that moment. So I think that's where I see the balance. And that's when we fall back on the trust for each other and knowing that everyone's got each other's backs. There's nobody in that team that is unclear about what they need to do if we're doing it right.
Yep. Okay, Rihanna?
And I just to pick up on that, Liza, yeah, I think within a hospital sort of healthcare system, I agree we don't really do incident control, to the depths of what it actually reflects. I would say in the public health network where you're working across interagencies, we are all trained, specifically in the Australasian Inter-Service Incident Management System. We have to be authorised officers. We have to do, tabletops and preparedness and really understand that role, because it's not a small team. It's actually, an entire statewide network of individuals that you would probably never have met before the crisis eventuates. And so there's a trust in the system, I guess, and that the person in those roles is prepared, but you may not have personal relationships and trust, which is different to often the surgical scenario where you're describing. And I would also argue that, while the surgeon might assume a command and control, just often by virtue of their, position, it may not be the appropriate leader. And we've seen that often in governance situations where through, whatever, that they might be distracted or not have that situational awareness or may not have the skills. And so I think in the official command and control inter-system sort of structures, you have a lot more of that planning and preparedness work, which I don't think we do as well in hospital settings.
Yeah, I spent the last 5 years in public health and through the pandemic, and I think the actual crisis helped to bring people together, and the trust was built very, very quickly, even though people didn't have established relationships beforehand. But there was definitely a feeling and a pattern that I noticed that the trust was there in terms of the competency of the public health leaders that came around the table. So there was no question about that. The trust was there in terms of the competency, and the relationships built very, very quickly. So that was interesting to observe that, because you're right, there is a difference, of course, from kind of provider on the ground and public health. But I noticed that command and control still had a high level of trust within it because the competency was there, even though the relationships weren't before the crisis.
I guess.
I agree. That's the same point. Yeah, that the trust can come because you trust the system and that those people are there for a reason, and so you can easily bring those people together.
Yeah, and just to round up that conversation, I guess the other aspect of that is also the risk of intimidation as well from a command and control structure that we've got to be very careful of, because whilst that can, we might think that as a result of that, the silence that we observe can mean alignment or agreement. It's often not. It can be a sign of intimidation or, stress in that situation. Now, Lewis has his hand up, and this is about the time that he throws a curveball into the equation. Lewis?
It might not be a curveball, but I just wanted to highlight a few things that we might just need to look around and see. So the world's in crisis. You can see the leadership of our politicians around the world right now responding to the war in Iran. You can see how it's been communicated by Pete Hegsworth and Donald Trump in the United States and the way they communicate to their audience, or the way Keir Starmer and Albanese have told their communities. We saw what happened to Albanese during the crisis of the Bondi massacre and what impacted on him, and in fact that he was pushed into making a decision about a royal commission that he didn't want to have because of the impact of his poor performance or proposed poor performance in communication. We saw what happened to Scott Morrison when he didn't hold the hose for the fires. And these are all well-established leaders who have done lots of training in managing PR, media training, everything else. But in crises, even surrounded by a flock of people, have made interesting in difficult made interesting decisions about the way they will communicate. But I bring back to our healthcare something that I challenged our public health doctor today. We got the influenza season. The right thing to be doing is getting the message out to vaccinate. Right now, and we know from last year, it was almost 30% vaccination in our public health sector, in our Metro North hospital health sector from our staff that we could record. And I said, how are you going to communicate the message out about influenza? And he said to me, in the same boring way we've done it before. We don't know another way to communicate. And I said, well, the same boring way we'll get the same results as last year. And it's a concern because even in something that we are well and truly tried and tested, we still aren't sure how to engage the community. We lost confidence, the community's confidence, for various reasons. Someday there'll be all the papers about how we communicated going during COVID. As a Queenslander, how Jeanette Young decided not to give a certain vaccine and recommended not to happen, and you got 2 weeks to go and get your food. All of those things mattered. I'm not sure how those positions now will hold the same authority if there was an outbreak now. I don't think they would around the country. I just don't think they would. And that's an important observation to make following then. Well, my final one is this one, Sydney. We were talking about the doctors and the disruption and the behaviour and the having your skills beforehand, or sorry, having your relationships in place beforehand in the crisis. It's interesting that when we practice the crises at the hospitals, whether it's cyber attack, whether it's your email system's gone down or a fire or something else, we try to practice the system, which we rarely get right. We do never practice the actual communication and test it. And we don't practice real-time scenarios where your decision-making is under pressure. And the only real test of the leader in this circumstance is the Prado adversity test, which is how will you respond under pressure yourself. And until you've been under pressure, and actually Tony's point about clinical pressure being very similar is very valid, because it doesn't actually matter until you're actually under pressure and have to make what I call a command decision. And Lisa, that comes from my time in the army, where I was taught at some point you have to make a command decision. Despite everyone else's opinion, you have to make a decision. Until you're under pressure, you don't know how you're going to respond. And so for myself, the question would be, when we're teaching and we're talking to everyone, is how have you responded under pressure? What feedback did you get when you responded under pressure? And how will you have modified your response or behaviours when they were under pressure? Because even those of us who teach other, say, doctors or clinicians, behavioural techniques often aren't ever having to demonstrate themselves under pressure ourselves. We know how to demonstrate it.
Yeah, absolutely. Great point, Lewis. I just can't help thinking, does Zoom technical malfunction count as a pressure situation? Okay, now
I was watching everything, Sydney. You were perfect. I had thrown the baby out in the bathwater, whatever it does, or the toys out of the cot. I don't know what I did.
All right.
I said never again for Zoom. That's what I did say.
I think we might need to wind that up, given the timing.
Sydney, can I just remind everyone, we do have the courses coming up on this topic, disruptive clinicians courses coming up in March, and also we have the health and finance and data and finance for healthcare in a week's time. For anyone who's interested, all the information is on the website. If you're a member of AIHE, you'll get them in your weekly updates, but otherwise look at the website for that course. And in particular, if you want to talk about leadership skills, our AIHE Foundations of Directorship course, both in person in May and online in May, coming around the corner. Great opportunity to undertake that training. A great course we had last year. If you are at all interested in developing your leadership and wanting to understand core leadership knowledge of governance, risk, finance, and clinical governance if you're in healthcare, that course may be for you. If you've already done the AICD course, don't forget that our 4th day on clinical governance for directors can be taken on its own, and it's just the perfect course to round off your skills in that space. Thanks, Sydney.
Thank you for that, Lewis. Does anyone have any final comments that they want to make? I just want to say this has been a very good discussion, and thank you for all of your attendance and patience through adversity. I think we've really demonstrated, persisting through adversity and persisting through crises, really. So my thanks to our panel and the audience for joining us today. This recording will be uploaded onto our website and onto our Spotify platform for you to listen to or watch as you wish. So thank you very much. And with that, I will end the round table and wish everyone a good evening.
Thank you, Sydney. Thank you all.
Good night.
Thanks all.